Welcome everybody. Today's topic of discussion is endometriosis. Basically, this is a panel discussion arranged by General Division of Sun Pharma and TOGS. Here is the list of panel doctors. Almost everybody is present here. Dr. Deepakar Mandal is here, and others. Somtam is also here, and Thomas Sudi. Anyway, the question goes to the audience actually. I will ask the audience. Endometriosis and enigma. What is the definition of endometriosis? Turun.
Presence of endometrial gland and stomach outside the endometrial cavity. It can be any location such as myometrium, ovary, POD, broad ligament, etc.
Thank you. Defined as the presence of endometrium-like tissue outside the uterus, which induces a chronic inflammatory reaction. Definition by ESHRE. The International Glossary of Infertility, they define it a disease characterized by the presence of endometrium-like epithelium and stroma outside endometrium and myometrium. Endometriosis is a disease in which tissue similar to the lining of the uterus grows outside the uterus. Common sites are there: ovary, fallopian tube, pouch of Douglas. Incidence of endometriosis.
10%.
Yes, 5 to 10% of the women of যদি তোমাকে পরীক্ষার নাম্বার দিতে হয় তাহলে পুরো বলতে হবে 5 to 10% of women of reproductive age. And in case of patient suffering from pelvic pain, it seems to be 70 to 90% of the patient they have endometriosis, and 40 to 60% of patients with dysmenorrhea, the root cause is endometriosis. What are the common sites? We have already mentioned. Still there is a list. Tell me. Common sites of endometriosis.
Ovary, broad ligament, pouch of Douglas, ligament.
Here is the list. Ovary 55%, anterior cul-de-sac 35%, posterior broad ligament 35%, posterior cul-de-sac 34%, and uterosacral ligament 28%. These are the common sites, and the uncommon sites are rectovaginal septum, bladder, appendix, peritoneum, cecum, umbilicus, small bowel, etc. Even sigmoid colon also. What are the common theories of pathogenesis of endometriosis? দিদি বলুন, অনেকদিন থেকে endometriosis ট্রিটমেন্ট করছেন, আপনি বলুন কমন থিওরি কি কি আছে? আচ্ছা, সম্ভব হলো
retrograde menstruation.
একটাই বলো,
Retrograde
menstruation. Right. Retrograde menstruation is seen in laparoscopy. If you do laparoscopy during menstruation of the patient, you can watch the blood is coming out of the fallopian tube. Endometriosis pathogenesis. Etiology is complex and multifactorial. These are the ideas: retrograde menstruation, coelomic metaplasia, changes, automatic change, metastasis, stem cells, and hormonal. Menstrual blood contains endometrial cell regurgitated via patent fallopian tube into the peritoneal cavity. In implantation, development, and growth of these cells into the lesion, which is later supported by the angiogenesis. Which hormone is the key factor, Dr. Mukherjee? Oh, sorry, আপনাকে বলছি। Which hormone is the key factor? Estrogen, right. Role of estrogen in the pathogenesis of endometriosis. Estrogen is the key hormone in ectopic endometrial tissue for growth and persistence, pro-inflammatory effect, vasculogenesis, and neurogenesis. Estrogen reduction, that is hypoestrogenism, is the logical target for treatment of endometriosis. Estrogen dependence. Ectopic endometrium shows high estrogen biosynthesis and low estradiol inactivation. Hormonal dysregulation is a cause. In normal menstruation, estrogen action through ER alpha is responsible for expression of progesterone receptor. In normal menstruation, this receptor makes progesterone receptor. That's why normal menstruation is happen and there is no endometriosis. But in endometriosis, estrogen dominance is there, and the actual molecule, actual site is ER beta. Estrogen dominance, cell proliferation and inflammation and angiogenesis. And there is a great factor, that is the progesterone resistance. Progesterone resistance is the key factor for estrogen dominance. Summary of the pathogenesis. High estradiol causes high inflammation, and there is progesterone resistance, that is estradiol has got an open field to play. Progesterone resistance, endometriotic lesions exhibit an overall reduction in progesterone receptor expression relative to ectopic endometrium and an absence of progesterone receptor. What are the confirmatory diagnostic tools? Sabram.
CBS. Gold standard.
This is no more a gold standard for Guru. Endometriosis laparoscopic visualization ideally with confirmatory history. Typical clinical symptoms, signs and uterosacral nodularity. And regarding MRI, transvaginal ultrasound, laboratories currently fail to show predictive value. X-ray guideline perform a laparoscopy to diagnose endometriosis, although evidence is lacking that a positive laparoscopy without histology proves the presence of the disease. In women with symptoms and signs of rectal endometriosis, transvaginal transrectal sonography is useful in identifying to rule out the rectal endometriosis. Usefulness of MRI to diagnose peritoneal endometriosis is not well established. What are the commonly presented pain symptoms?
Dysmenorrhea chronic pelvic pain.
Right. Dysmenorrhea, number one. Incidence of dysmenorrhea?
60 to 70%.
77%, right. Infertility,
30 to 40%.
incidence? 30 to 50%, yes, 40%. Non-menstrual pelvic pain, endometriosis,
50 to 70%.
34%. Dyspareunia, incidence? 23%. What are dyschezia? Dyschezia. Dyschezia means painful defecation. Commonly presented pain symptoms in endometriosis already mentioned. Location of DIE, deep infiltrating endometriosis. What are the location? Torun,
Rectovaginal septum, POD, uterosacral ligament.
Yes. Anterior compartment, urinary bladder, uterovesical region, periurethral region, posterior compartment, uterosacral ligament, thorax uterinus, posterior vaginal fornix, rectovaginal septum, vaginal wall, anterior rectum, anterior rectosigmoid junction and sigmoid colon. These are the sites. This is the location of DIE in bladder. This is a picture of deep infiltrating endometriosis in bladder. Terminology. These are the interesting terminology. You may know. That's why I have incorporated this slide. There is a comet tail sign. মানে ধূমকেতুর লেজ। ইন্ডিয়ান হেড ড্রেস ডিজাইন, ইন্ডিয়ান হেড ড্রেস ডিজাইন বিনুনির মতো। ইন্ডিয়ান হেড ড্রেস sign plus comet tail sign. This in ultrasonography, if you find this, you may be sure that this is because of endometriosis. Ultrasound finding in adenomyosis. What is the difference between adenomyosis and other growth of uterus? There is asymmetrically enlarged or globally enlarged or abnormal myometrial echogenesis. Fan-shaped shadowing, rain in the forest sign. These are ultrasonographic, specially ultrasonographic findings. Dr. Oswaleর ভালো বলতে পারতো, এটা ডক্টর অসওয়ালের ফেভারিট খাদ্য। যাই হোক, মায়োমার সঙ্গে অ্যাডেনোমায়োমার কি ডিফারেন্স আছে ইন আল্ট্রাসোনোগ্রাফি? Myoma will circumscribe round, oval or lobulated and solid and sticky shadows. In adenomyoma, in circumscribed area, echogenesis is different from surrounding myometrium and fan-shaped shadowing, মানে ফ্যানের মতো ঢুকে গেছে। এখানে পরিষ্কার বোঝা যাচ্ছে ফ্যানের মতো ঢুকে যাচ্ছে। ফ্যান মানে সিলিং ফ্যান। What are the treatment options? ট্রিটমেন্ট অপশনস কে বলবে? হাত তুলো। না ওই মেয়ের মধ্যে পেছন দিকে, এই পেছন দিকে রয়ে বলো, সেটা খেতে ব্যস্ত আছে। ওকে,
satisfactory treatment options. Surgically only surgery can provide 100% cure but not satisfactory.
ট্রিটমেন্ট অপশনস হচ্ছে নন হরমোনাল এনএসএআইডি or anti-angiogenic, that is gabapentin, and hormonal GnRH agonist, progestins, that means diagnosist or Mirena. Okay, oral contraceptive pill, GnRH antagonist and aromatase inhibitors. Drugs, estrogen progesterone combination or progestins or GnRH agonist, তার মধ্যে যেগুলো আছে লিপ্রোলাইট সবাই জানি, নেফ্রোলিন, গ্যাসোলিন, বুসোলিন, ট্রিপ্টোলিন, androgenic steroid danazol of no choice today, anti-androgen sapropterin acetate, GnRH antagonist elagolix, aromatase inhibitors letrozole or anastrozole. এখানে আমি একটা কথা বলি, anastrozole মানে অ্যাডোভা। severe endometriosis, I have prescribed Adova 2 mg daily. 1 mg is available. 2 mg daily for 3 months and patient consent. Recommendations by the guidelines. Foxy guideline যেটা দিয়েছে সেটা হচ্ছে যে only COC or progestins or GnRH agonist. Till now Foxy recommendation এর মধ্যে GnRH antagonist ঢোকেনি, যদিও DCGI ঢুকিয়েছে, আসছে সাথে। What is the ideal solution? What is the ideal solution? No. What is the ideal solution? Partially suppress estrogen enough to treat symptoms while maintaining sufficient levels to prevent hypoestrogenic effect. Cut down the effect of estrogen, not up to the level of hypoestrogenic condition. How this is achieved? Gonadotropin releasing hormone binds to GnRH receptor, stimulates release of FSH LH from antipituitary and ovarian steroid hormones release, that is estradiol, in normal menstrual cycle. What elagolix, that is GnRH antagonist, do? Competitively blocks the GnRH receptor. The dose dependently suppress the production of FSH and LH from antipituitary. It inhibits the secretion of estradiol without inducing flare-up effect. How does elagolix provide the ideal solution in endometriosis?
Dose dependent inhibition of estrogen.
Oral GnRH antagonist with superior benefits. It rapidly suppresses LH and FSH, and thereby, I already mentioned, suppresses the estrogen progesterone secretion. The key milestone, trial in 2004 and phase 2 trial was advanced also in 2010, US FDA approved in 2018, and US FDA approved for treatment of uterine fibroids as well, and now the Drug Controller General of India DCGI has approved this year. Indication management of moderate to severe pain associated with endometriosis, and those as already mentioned. Beyond endometriosis, the role of elagolix. Elagolix in heavy menstrual bleeding associated with uterine fibroids and uterine fibroids. Does it work? Who is it?
TSC dot.
Hello? No idea.
TSC dot.
No idea. Okay. Right. Till now we don't have any idea. Theoretically. Elagolix 150 mg once daily effectively reduced heavy menstrual bleeding in premenopausal women with uterine lymphomas, showing significant improvements over placebo and was well tolerated without new safety concerns. Beyond endometriosis, the role of elagolix, there is another one role. Role of elagolix as pre-IVF in endometriotic patients. Endometriotic patients, you have advice for IVF, and before sending the patient to IVF center, you yourself can try with this. Patient might conceive after the treatment, after the withdrawal of the drug. The patient might conceive and credit goes to you. This is still under study. The result is on the positive side.
Sir, is there any contraceptive role of elagolix?
Yes, of course, there is contraceptive role of elagolix. Of course. Already slide is finished.
Sir, one question.
Question asked.
कैल्शियम और विटामिन डी की सप्लीमेंट को
BMD.
Yes. Hypoestrogenic condition means low BMD.
सर बिकॉज दिस हैपेंस
Low BMD. Naturally, you must prescribe as a supporting therapy of calcium and vitamin D because
But
it
this is
decreases
the-
BMD. It decreases BMD.
But they said that up to 6 months there is no need of calcium or advert therapy.
My dear.
according to phase 1 and phase 2 trial reports there is no need of giving any supplementary dose, and if you continue it for more than 6 months, that means up to 1 year or more than 1 year, still the data shows that the BMD level is almost equivalent. Actually they have extended that study. Actually in one group they have given placebo, in one group they have given 150 milligram, on second dose they have given 200 milligram twice daily, and the third participant they have given along with estrogen and progesterone. Ultimately this has been shown that the low dose and the high dose, in the high dose the BMD is bit reducing, but in case of low dose, that means 150 milligram once daily dose, and those along with the estrogen and progesterone, that means norethindrone and estradiol, in that cases the BMD score is almost equivalent even after 1 year. That means that is a result of the phase 3 and phase 4 trial. That result is in our hand already. But the thing is that what is the lipid profile and what will be the neurogenic effect, there are so many other aspects, that data is not still in our hand. But the result is very excellent regarding the hypoestrogenic state, and in indications where you are using, that means the dysmenorrhea, non-menstrual pain, dyspareunia, all in cases that is excellent effect. We can do a estradiol level. we can assess the patient by doing a estradiol level after 3 months. If the our desired estradiol level is 30 to 60, okay, if the estradiol level is in between, then there will be no carrying out that the hypoestrogenic conditions. If it is less than 12 or 20, that means what is used in case of 200 milligram twice daily, that means in case of severe dysmenorrhea or in case of dyspareunia. In that cases, we have to concern about the BMD level, and we have to assess the patient by doing estradiol level after 3 months, after 6 months, or after 1 year. Then we can judge the patient whether that patient need any supportive treatment or not.
Thank you.
And no period in between.
Now, madam.
No withdrawal bleeding in between. No withdrawal bleeding in between.
No, madam. Period হবে।
হবে।
ওরা দাবি করছে স্যার আপ টু 6 মান্থ
High dosage
দিয়ে দেখুন
আচ্ছা।
আপ টু 6 মান্থ কমপ্লেক্স সাপ্রেশন হচ্ছে না ডোজ ডিপেন্ডেন্ট সাপ্রেশন ডোজ ডিপেন্ডেন্ট হবে
হাই ডোজে হবে না কম ডোজে হবে?
কমপ্লিট ডাটা নেই
সমাজ কারণ এই ওষুধটা এটা দিয়ে দেখতে হবে
এটা হচ্ছে যে এটাগুলি স্পোকন অফ প্রেগন্যান্সি
ট্রাই করবো আমাদের পেশেন্টকে কাউন্সিল করতে হবে।
কারণ কমপ্লিট হাইপোস্টেনিজম হচ্ছে
প্রেগন্যান্সি থেকে অ্যাভয়েড
স্যার বসুন
বসছি কোল্ড ড্রিঙ্কস দাও তো একটু ওষুধ আছে
স্যার বলি